Our next speaker is Dr. Max Dachura of the Medical College of Georgia, who is a professor in the schools of medicine, nursing, and graduate studies. And he tells me that the Medical College of Georgia is soon to be no longer the Medical College of Georgia, so I'll let him explain all of that. It's kind of an interesting story. He is also the eminent scholar in telemedicine and director for the Center of Telehealth at Georgia Research Alliance. So he wears a number of hats in a number of different departments. For InHealth, he is conducting a rather intense study of the differences in therapies for diabetes, which is a big deal, as you know, in healthcare and also in the payment community. And he will be able to tell us more about that now.
Thank you. With that opening comment, let me just tell you that our new president has decided that the Medical College of Georgia doesn't describe our institution adequately. And so we will, on February 11th, become Georgia's Health Sciences University, and the 200-year-old name Medical College of Georgia will apply to the School of Medicine. First of all, in deference to our previous speaker, I have no conflict of interest to report in any of the studies that I'm about to present. Second, please don't think of it as my presentation. It couldn't be done without my collaborators. And by way of background, we chose to study diabetes, or this aspect of diabetes, because of the magnitude. These are even a few years old. 21 million Americans, 7% of the population with diabetes, 6th leading cause of death on death certificates in the United States. The Lewin Group figures are about 5 years old, 92 billion in direct medical cost, 40 billion in indirect cost, and that's annual cost. What we have chosen to study is intensive insulin therapy. There are many studies in the literature that document that if you can get patients to really administer insulin intensively with multiple daily checks of their glucoses and multiple injections of insulin in order to reduce their glucoses to near normal values, you can delay or prevent the complications of diabetes that are so devastating to the person's life and are so costly to care for. There are two major techniques that really work. One is called multiple daily insulin injection, and this is where the patient sticks their finger 4, 5, 6, 7 times a day, before and after meals, at bedtime, first thing in the morning, and times their injection of a variety of different insulins, usually at least 2, perhaps more, different types of insulin that are given each day. This technique will bring the glucose down to near normal values if applied properly. The cost is syringes and insulin. There is also a therapy known as insulin pump therapy, where a programmable pump is worn on the patient and infuses insulin in a more physiologic way throughout the day, with surges in relation to meal intake. The difference between these two, they're both effective, is that the first one costs syringes, the second one, initial cost, is thousands of dollars. So in terms of the value equation, why do pumps? So what our study was about is not whether or not multiple daily insulin injections or insulin pumps could control glucose. We know it can do that. And we know that either one can be effective. We also know that by trying to study patients who are using these two techniques, we've already selected a highly motivated subset of the general diabetes population. So we know that they are going to be happy when either one of these techniques results in improved glucose control, because they're motivated to do the work that's required to get it done. we're using standard evaluation techniques to evaluate the impact of these two techniques on the patient life. And by that we mean is, are you in control of your diabetes, or is your diabetes in control of you? If you're in control of your diabetes, and you can go to school, you can participate in church groups, you can have a job, it's not intrusive in your life. And our technique was to do surveys, or is to do surveys, because we're about halfway through, but do surveys of two different groups of people. One is the patient, him or herself, if you were looking from the inside. What's the impact of using this therapy on me and my ability to interact with the world? And also we ask the patient to select a significant other. It could be a family member, a church member, a friend, a neighbor, a child. The person you talk to about your diabetes, other than your physician, other than a nurse, the person who day in, day out knows what's going on with you and how diabetes is affecting you. Importantly, we are looking at both type 1 and type 2 diabetes. And the reason this is important is because current reimbursement, let me say for Medicare specifically, approves insulin pumps only for people who have blood sugars less than 225 milligrams per deciliter, which is about twice normal, but also with a C-peptide level that is down in the normal range. C-peptide is a marker of endogenous insulin secretion. By imposing this rule, Medicare has effectively eliminated reimbursement for type 2 diabetes. Type 2 diabetes represents 95%, 90 to 95% of the diabetes population. Medicare also, at the time of passing into seniority, changes the insulin pump from ownership to lease, which means that you don't get the upgrades to the most effective one as quickly as you can under private insurance. So we looked at type 1 and type 2, we looked at type 1 and type 2, which is not normal. And we also didn't care about age, as long as you were an adult. Both patients and their significant others were compensated for filling out the forms. First phase was to develop and validate the questionnaires. Took us most of the first year. We are now in phase 2. We have about half of the way through collecting data. The preliminary results I'm going to describe to you are based on the 261 paired studies. If we don't get a paired study back, we don't look at it. And we are going to analyze this by age, by educational level, by gender, by race, by a variety of specific parameters. But with deference to our first speaker, I'm going to give you results in this preliminary fashion that are based on Likert scale, and you'll see why in a moment. First, let's look at management, whether or not the patients who are satisfied, do these techniques help me manage my diabetes? And all I want you to look at is that whether you use an insulin pump, or multiple daily injection, the patient's very happy with it, okay? But most happy with the pump. And that impression, given independently by the significant other, is the same.